Hello, one and all, to another episode of the EMS Pod with Chief Randell. Today's episode, I want to focus on what we like to call EMS research. It's a phrase that sometimes go together very well because you can see the progression of the field. In other areas, it seems scary because it's a big topic. So I have a couple of my close research friends with me today that's going to break down this topic to a level that is feasible and digestible. I like food. So we'll start with Dr. Crowe, Dr. Kennel, discussing their backgrounds as results to research, and we'll dig into it. Dr. Crowe.
All right, yeah. So I think my path to research was not exactly a straight one, which is probably true for a lot of folks. I started off as a volunteer EMT in Mexico City, and then I became an EMT instructor. And as I was teaching and looking at our textbooks, it sort of dawned on me that a lot of the things that were in the textbook sounded like good ideas that probably came from the hospital setting, but how do we know that these are really the best thing to be doing in the pre-hospital setting? And I always wanted to be one of the people who could contribute to one of those books. And so I thought, well, the path to do this is probably I've got to get into research. And how do I do that? Well, maybe I'll become a physician. And so I thought about enrolling in medical school, but I actually went to a conference on my vacation one year, and I met somebody from the National Registry of EMTs who told me about a research fellowship. And it was a really great opportunity that I applied for and ended up winning, and was spending 5 years in Columbus, Ohio, where I had a full-time job doing research at the National Registry, as well as working on my PhD so that I could become an independent researcher and studying epidemiology and biostatistics. And then after that, there's no stopping me now. I've been in research for the last, I don't want to count the number of years. We won't do that. But it has been an exciting path. So now I lead the research operation at ESO.
Very good. Thank you, Dr. Kim.
Very exciting. Yeah, I don't have the nerd status to go to a research conference on my vacation. I
There
wish
was
I
free
did.
lunch.
That's impressive. Yep. Yep. So let's see. My path to research, I think it was twofold. One is working as a paramedic, wondering why do we do the things we do, and how do we make changes to the things that we think we need to make changes to? Is it really just some dude or some chick's medical director saying, this is my opinion? And so as I started to dig into it more, learning, no, there needs to be some evidence, and there needs to be some rigorous evidence around making change. And so as I was working as a paramedic and completing my PhD and doing some teaching in EMS, I think understanding how to do research is really going to be the way to start to make some improvement and some change to the industry, rather than, for me personally, working one patient at a time. So completed the PhD, taught as a program director for a paramedic program for about 10 years, and now do research and teach at a medical school.
Wow. You know, paths can be different, but we're still at the same end result. And the question, I guess, the general basic question that clinicians would have that work on these streets is, why is research so important? What does it have to do with them?
I always say, well, if we knew what we were doing, it would just be called search. So it's important to do research to help us evolve in what we're doing and make sure that what we're doing is the best we can do with what we know today. And we should expect that what we know is going to change, and our treatment and our care is going to change. So I think it's important for us to have that open mind, in that we don't know everything about everything. We've got hypotheses, sure, things that make sense, but a lot of times once we get some data behind that, it turns out what we're doing might not be best and might actually even be causing harm. So I think it's important to keep us honest and to keep us doing the right thing for our patients, is to follow the data.
I think, let me just add one thing to that, because there's one way to think about what Dr. Crowe said, which is we need to figure out, does drug A work better than drug B, which is important and a valid reason to do research. But the thing that I think excites me about research and why it's important also is it helps us understand reality. And what we often see in our own brains due to our own ego and our own perceptions is not reality. And so it gives us a view to what the world really is versus what we think it is, which is kind of a fascinating to me make-believe movie land of what we think is out there and what we think we're behaving like is really not how we're behaving. And until we do research to uncover that, we don't know what reality looks like.
You know, I've always been told since I've been in the business that this is a outcomes-based process. And I think as I've learned about research, that research makes it objective and it makes it, it gives you answers to what you're doing. And sometimes you find out that you're really not doing the best thing, mass pants, for the patient, right? So let's do something that could be better. Good, good. So in your experiences, what have you witnessed as a researcher that maybe has made a difference in what we do today when it comes to patient care?
Sure. I think there's a lot of things that we've seen. EMS is relatively young as far as professions go, and we should keep that in mind. And we've seen a lot of evolution in, starting with the kind of research that we mentioned at the beginning, treatment A versus treatment B. We've seen a lot of evolution in what we're doing. We don't routinely carry around mask pants anymore or EOAs. And so research has helped us shape our treatments in terms of what we're doing. For example, there have been a lot of randomized control trials even. So Rampart was a study around status epilepticus. What's the right dose and the right medication, the right route for a patient having a seizure? And then, to Dr. Kennel's point, there's other research out there that we're using to bust some myths. And we'll probably talk a little bit about a paper that we collaborated on recently, but we think that we treat all patients equally, and we hope that we do. But what if the data tell a different story when there are systems in place that are giving rise to different results? And so we looked at, for example, racial inequities in analgesic administration, and we found that there actually are inequities in care, and that there are things we can do about it. So research has helped shift our mindsets on some of these things and had us examine how do we want to approach our systems and how do we want to make sure that we are doing that thing that we think we're doing, giving the best care to everyone.
Nothing to add. That was perfect.
That's rare. I'm confused.
So even with some of those, with that particular research that you share with Dr. Kennel, what were some of the things that you actually found specifically?
Yeah, I'll take this one. So in general, and across a number of different research efforts, what we found is the belief and the desire to treat people the same when they have the clinically equivalent condition is misplaced, in that we want to treat everybody the same, but we often don't. And we're influenced in this case by social characteristics such as race. Similar research has been done showing that providers are influenced by gender, by obesity status, by trans status, by sexual orientation, to provide different levels of care based on those social characteristics. And again, as Remle pointed out, this is inadvertent and not the intent of the provider. However, we see evidence that this takes place.
Okay. So sometimes research can help you bring a topic to light that makes you more aware. So the next time you visit with a patient, then that's in the back of your mind that I need to make sure that I'm not part of that research. Would that be a fair assessment?
It can, yeah. We hope if it's done right, it causes some reflection, right? And I think there's some steps in that process that much of the research has been understanding if a disparity exists. We're moving to a space, thankfully, that is now understanding why does that exist? And then what are the interventions to see, we think we know we can fix it or address it, but let's test and do some research around what are the interventions in order to fix this. And to your point earlier, Chief Randell, if research is done well, it can provide us with objective, clear answers. But it's really hard to do it well also.
And I'll add to that, I think when we get into the research and get into the data, it helps us challenge our assumptions. So if I ask you, how well do you treat patients with pain who have a long bone fracture and a pain score of 7 or higher, you say, oh, well, we probably treat all of their pain. But when you actually step back and have the humility to take a look at your data, you might see that you're in line with the national average, which is 74%. So 1 out of 4 patients with a broken long bone who has severe pain, who was treated by an ALS agency, who was conscious during the entire transport, didn't get offered analgesics. And that is where research and improvement science come together. So you, as a consumer of the research and as a person of influence within your EMS organization, can say, wow, we need to look at our own data and see where we compare and where we can improve our system, and maybe not just assume that we're giving the right care all of the time. And again, it's not usually an intent. The first rule of quality improvement is every system is perfectly designed to get the results it gets. But starting with the research and using that as the impetus to move into a quality improvement space is a really strong place to be.
So when it comes to research, I hear that there was a conference a couple of weeks ago, the NAEMSP, and they really dig into research and they look at ways of moving this profession, this young profession forward. Was there anything that either of you have heard or saw that piqued your interest?
Oh, we would have to do a whole series of episodes for that. But I think for the audience understanding, the NAEMSP is the National Association of EMS Physicians, but though that P stands for physicians, there's a great deal of professional members. In fact, we are about a third of the organization now. And there was research presented not just by physicians, but there was a lot of great paramedic-led research, including on the main stage. So when research abstracts are submitted, they are either accepted as a podium presentation, which is a lightning 8-minute presentation, or a poster presentation. And on that podium is that highest level of honor, and it's a very small percentage of abstracts that make it there. But there was a great number of abstracts by paramedics, including mechanical versus manual ventilation. Are we underusing the power of mechanical ventilation, for instance? There was another interesting study looking at the influence of homelessness status on patient care and transport. And then I don't like to brag on myself, but we presented a really innovative data set looking not just at encounter-based data, which is traditional EMS data. You get 1 PCR, and if you see that patient again, it's a new PCR, and we're not able to track that patient-centered care. We've created a database now that is patient-centered, and my team and I studied 72-hour return visits after that initial non-transport. And so we can start to answer questions like, what is a high-risk non-transport? And I purposely avoid the word refusal because there's a lot of stigma attached to that word. It's hard to understand who initiated the refusal, as those of us who have lived in the field know. And so we started to put a number behind that. It's actually 6% of non-transports result in a repeat encounter in 72 hours. And that was actually awarded the best scientific presentation at this conference. But there's so much going on, including trials, looking at things like dual sequence defibrillation, ultrasound, you name it. But these are the things that we're going to want to keep our eyes on.
Important, I think, to amplify what Dr. Crowe said is at this conference, which is the preeminent conference for EMS physicians and EMS providers, there's research being presented from EMT students all the way to rock star researchers that this is all they do, and they receive multi-million dollars of grants every year. So the whole spectrum is available to see at this conference. So it doesn't require you to have a PhD to even submit and present at this conference.
Wow, that's exciting. I did not know that you had EMT students and paramedics presented. So now my eyeballs have gotten bigger. So how does somebody get involved into EMS research? You're at an agency, you're on the truck, and you read a couple of articles, you're excited about it, but where can it go?
I think this is the important thing to emphasize is that having EMS clinicians on papers makes them stronger, and not having those who live and experience and collect these data can lead to disastrous consequences in interpretation. I'll give you an example of a paper, and you all will pick it up immediately. Is a paper was published in a relatively prominent journal that says it takes EMTs 20 minutes to start an IV. And you're like, what? But guess how they calculated that? And this was a group of nurses, but they calculated it from dispatched to the time the IV went in. So we all look at that and we're like, no, but there was no paramedic or EMT on that paper who could have stopped and said, hold on, that's actually not when the clock starts. The clock starts at patient, correct? So I want to emphasize how important it is that we participate in, that we shouldn't be intimidated. Research is truly a team sport. You don't have to know everything about statistics to participate. You have a methodologist and a statistician there. You have a clinical mentor. So I would encourage, if folks come to your EMS agency saying, we would love for your organization to participate in the next trial, that we opt in and we choose to participate in that. If you receive a survey, choose to participate in that. And then Jamie and I work closely with an organization called the Pre-Hospital Care Research Forum, who hosts, we call them speed dating for research events. It's a 3-day workshop where you're given all of the resources to be successful and dip your toes and see if you truly like research. We hold different ones throughout the country. You can go to prehospitalcare.org to see when the next ones are coming up, but highly recommend that if you're just curious. No prior experience necessary or assumed. Encourage brand new folks to join this, but having those relationships and looking for those mentors is the way to do it. Don't do it by yourself. Find a team to do it with.
Yeah, and don't feel like you need to do it by yourself. If you're at an agency and you're not associated with the university, go to your medical director and say, hey, I'm interested in getting involved in research. Often your medical director will be involved in a number of research studies and hopefully can get you plugged in.
Yeah, I want to share my first research opportunity and how I got to know a couple of the folks at the national level when it came to research. And it was basically about documentation. And when it came to documentation, I wanted to know if people are taught a standard in how to document a run report, will it improve their patient care and the way they document? And spoiler alert, it did, which was fantastic. But I didn't have the background in research really to understand all the terminology and the details of it. So I was able to connect with Dr. Crowe and also with Dr. Hezadine Smith, who for me personally was like, wow, there's another African American who's into research. Because initially I thought I was the only one that researched because I didn't see anybody else like me. And so when Dr. Crowe introduced me to Dr. Smith, as a tag team, we all three of us completed the research project, and everybody had a role in the project that was prominent. And in the end, it was a great product, not because my name was on it, but because, like you said earlier, Dr. Crowe, because it was a group project and it worked well. And I felt the most proud, I was most proud of this because it came from a place of zero for me. And if I can speak to the power and importance of research, I would tell others, if you're thinking about it, you should do it. And these are some good people that we're talking to that can help.
And I think Chief Randell's too humble in that not only did he start from, hey, I'm curious about research. I know that I would like some mentorship in this space, but he ended up winning awards for this presentation. He'll never toot his own horn, but I will. And I think it's just phenomenal work that came from his passion and his willingness to seek others to help and complement this team.
And not only, yeah, we're winning a research award, but also I think it gave you some impetus and some evidence to say, maybe there is a company behind this. Maybe I can encourage others to improve their charting, to improve their care, right? Seeing that evidence so clearly presented to you, I assume gave you some confidence that maybe there's some marketability behind this.
Yeah, I mean, yeah, it did provide some confidence, and you think that you can package it up and hopefully show the world that there is something valuable and that it can be replicated. So we're always looking for more research, right? So let's validate. Wow, that's a lot of information, and we hope that this is really a class 101 on research. And I would love to have you two come back and we can dig more into some of the 201 version of research here in the coming months, because I think this is a topic that should grow. And I think it's going to grow the number of people who perform research, because it really isn't as scary as most people think it is. So I thank you for bringing it down to simplistic terms and helping folks understand, you know what, I can do it too.
Happy to. Thank you.
No, thank you. I really appreciate both of you coming on and to keep your time and my time honest. And we're going to keep this short and simple. And for all the ones that have listened, if you have questions about research, if Dr. Crowe would mind to give the website again for the pre-hospital care forum.
Yep, it is prehospitalcare.org.
Jump on, find out. Let's do some research. Thanks again, and you'll hear from me again next month. Thank you.